have worked in aged care in a variety of settings, and then went into oncology and had the opportunity to get more into health reform and improvement and quality. And so I'm extremely passionate about having choice and people's rights from all generations, but particularly people that are our older Australians, and particularly those people that are vulnerable. One of our key things is to form relationships and collaborations so that our work can be taken up by others and delivered to lead to improvements across Australia and across particular sectors and population groups. It's really an opportunity for people to have a choice and control over their future healthcare decisions. So it's embedded in autonomy and human rights that people should have some say what happens to them at any time. Even for ourselves as a younger age group, I will say that we have a choice, like if something unforeseen happened to us as we left work today, what choices would we want made for us? So it's certainly relevant for any adult person, and who would be the best person to make those choices we need to consider. But particularly for older Australians, advanced care planning is very relevant as they come towards the end of their life. It really promotes this choice and control. So it allows people to legally appoint a substitute decision maker and to document either their values or specific instructional preferences. And they may mean that if they document instructional preferences, it can be consent to a particular treatment, refusal of, or withdrawal of treatment. So they are legally binding documents that various groups have obligations to follow. So the person documenting an advanced care directive, whether it be appointing somebody to be their substitute decision maker or documenting those instructional preferences, they have to have capacity to do so. So they have to be seen as having decision-making capacity. They only come into effect when that person loses decision-making capacity because, of course, while we're still competent, we are able to consent and make our own decisions for treatment. So registered health professionals and ambulance service staff have obligations and this is particularly under the Victorian Act, to access and to enact somebody's advanced care directive. They have obligations that they have to follow those instructions. Where there's a gap then is unregistered professionals, and particularly then in aged care related workforce don't necessarily, like personal carers, nurses, assistants in nursing, don't currently have obligations within the law about their role in following an advanced care directive. And I'll talk to you more about what we're doing as Advanced Care Planning Australia to try to address that policy gap here. And we know that there's benefits in advanced care planning, that it does lead to more easy decision making for family at the end of the person's life. If they know that that's what the person had wanted and expressed to them, they often have less issues with grief and bereavement and that suffering. The person themselves often feel like they had more control over the decisions that were made at their end of life. So in Victoria, there was a new act that came out last year in March of 2018, the Medical Treatment Planning and Decisions Act. And that really, it's a fantastic act. It really, again, put this move away from best interest, treatment of people and allowing people to have this choice in their future healthcare. And what it also added into the legislation is the ability for somebody to put in place a support person. And meaning recognising particularly people with dementia can have fluctuating decision-making ability, and they may be able to make decisions at a certain level, and we should be encouraging that decision-making. And so the support person has a role in that. So considering that decision-making isn't just either you're competent or you're not competent. And so therefore the support person has this role in the middle, and then the substitute decision-maker has the role perhaps at the more pointy end of making specific medical treatment decisions. They may be the same person that's been appointed into those roles, but they may not be. And again, the Victorian government is updating the Guardianship and Administration Act again to allow people to have more control over their own choices, and that those people acting on their behalf have to do a substituted judgment of what the person wants and not what they think is best. So Advanced Care Planning Australia wanted to look more closely at the aged population, knowing that it's a key target group and that this is really important towards their end-of-life care. And so we looked at, we did a pilot in 2017, and these are some results actually from our rollout of it in 2018, where we had 100 sites participate. 58 of those sites were from aged care, were residential aged care, and then the other sites were general practice or hospitals. And this is the overall result. So there was more than 4,000 older Australians' records audited to see if there was any form of documentation in those records. And overall, it was 25% prevalence of documentation. And certainly, like the statutory forms, which are the forms that the law provides, and they're the forms that would ensure that it is well recognised and should be complied with. And the first one there, that's 6%, is where people would put these instructions or their values into these forms. So only out of this 25%, only 6% of them were those forms. People were more likely to appoint a decision maker, and that's not surprising. That's really one of the key steps, and perhaps it's the easiest step in a way to appoint somebody and to have that conversation with them as the decision maker. It allows some good flexibility depending on what the clinical situation is. And then many others have done non-statutory directives, but we know from those, just as I was saying, that might be where somebody has written a fairly formal looking document but still may have forgotten to have a witness signed, put their date of birth on it. And so there are certainly higher issues with the quality of those documents that are out in clinical records. And there's questions whether the doctors would actually follow them. So what does it look like in residential aged care? Well, it's higher, of course, than that average because the prevalence was quite low in general practice, like very low. It was only about 6%. In hospitals, it was a bit higher, around the 17%. And then in aged care, it was 38% of the cohort that we included in our study, which were, I think, over 2,000 of them were from aged care, and 38% had some form of these documentations in their record. So obviously that's, that's a moderate rate. I wouldn't say that that's terribly low. The range was interesting. So some of the organisations that participated in our study had zero. They were found to have no form of documentation of the 50 random sample that were audited, through to some organisations having 100%. And either end of that spectrum can be problematic because you don't want to force people to do this. Not everyone wants to do advanced care planning, or not everyone has somebody to appoint or has the ability to write their own directions because they might have dementia and not be able to do that. So, either end, there was areas for improvement. It's hard for us to know what the actual rate should be. We do believe it should be higher than the 38%, and I'll explain when I talk about the third point there. So, just to highlight that only 17% of Australians with dementia had any form of advanced care directive. So that was quite concerning, considering their lack of ability to make their own choices, or once they get into that setting, have the ability to write their own documentation. So we've got a lot of work to, all of us, got a lot of work to do in that space. Interestingly, when we were searching for these documents, we searched for all forms of advanced care directives, and we also searched for medical orders. So that's where doctors might write, not for resuscitation or don't transfer or goals of care. And just to tell you that those documents were only found about 25% of the time in residential aged care. So that was an area that certainly could be increased. But we found documentation in people's files, or 30% of documents that were found in residential aged care had been completed by somebody else and not the person. And the legislation only allows for the person to complete this document. So there were a lot of times where family were being asked to, or perhaps had, you know, who knows, they may have proactively done it themselves, had written these documents.
Or not to be resuscitated.
Well, actually, that's the next point I was going to say.
Yeah.
So of the 30% of documents that actually aren't legally valid because there's currently no law to cover somebody else writing these, 68% said do not resuscitate. So if a nurse, doctor, whoever followed that document and didn't realise it was clinically invalid, somebody had written to not resuscitate that person. It may be their preference, but there's no legal framework. I can't just write at the moment, you know, don't resuscitate my husband. You know, yeah, that's right. It's certainly an avenue of risk around elder abuse. That there is so much of this activity. So when you think 38% were done by the person and 30% were done by somebody else, so it's nearly half of the activity is legally invalid and at a serious risk to the sector and to the person and to the families and to the treating doctors in this situation. You can look at it another way as well and go, wow, well, aged care have actually got nearly 68% of people in aged care doing some form of activity. They just haven't got the guidance yet around who should be filling out these documents, and that they should be filling out the documents should happen earlier so you're not reliant on the family to do it. So I think it's quite impressive that there's actually 68% of activity occurring in this space.